Uh, Doctor, as we open this up here too, for the audience and the readers and the people watching who may not know you, share a little bit about your background and how you've become a leading expert in men's sexual health and performance.
So I grew up in a small town in Canada, and my 12-year-old self would never have imagined that I'd become a urologist, let alone someone with an interest in sexual medicine. And so I went to med school. There was nothing else I wanted to do. Uh, was fortunate to train at a university where we had Canada's leading expert in sexual medicine. Um, Following that, made my way to the University of Washington. I still live in Seattle, where I was on faculty and did a fellowship in trauma and reconstruction. And while I don't do a lot of trauma anymore, what reconstruction is, if we get right down to it, it's genital surgery. So I have worked below the belt for 25, 30 years. I started med school 30 years ago this month, and so through my career doing general urology and just the evolution of my career in private practice, I took my reconstruction skills to, prosthetic urology. And prosthetic urology covers things like male incontinence, and it covers impotence, and so penile implants. And so if you're going to call yourself a penile implant doctor, you also have to know sexual medicine. And so the evolution of my career and my training brought me to that point. And so I've been in practice for 18 years where I am. Ironically, almost sort of as a midlife male pivot. I'm leaving active practice at the end of this month. Experiencing some burnout from maybe corporate medicine, a need to take a break to find my way back on my terms. But that's the quick story about how I got here.
From your vantage point, what are the most misunderstood aspects of sexual health, for men?
I think that there's a couple of things. I think one thing I want men to always know is that there's rarely anything that you will ask us that we haven't heard. And that gets sort of wrapped up in the shame and the silence and in the I'm at the doctor for something else, but I'm really here to talk about sexual medicine. And so it's that typical doorknob complaint. You're getting up to leave, and then all of a sudden you're like, oh, there's one more thing. And so talking to us about these things is nothing new, and making an appointment for these things. And so I think just sort of the misconception is that we don't want to talk about it. Now that's not necessarily across the board. And so important in that is finding a urologist or a men's health primary doc or a concierge doc who treats men, who is comfortable treating men, who is comfortable having these discussions, just like finding a coach who's comfortable treating men in these transitions. I think the first thing is not all docs are created equal, but when you find that person, find that fit, these discussions are every day for us. I think the other thing that men get caught up on is chasing 30 years old. Instead of chasing 55 or chasing 57 or 49 where they are. And I think that that's actually the biggest misconception. And then the other misconception is just all the stuff that I think comes through the text messages from what I call your best friend Joe. Your best friend Joe sending you text messages. Have you seen this? Have you read this? Go try this, go try that. Men are bombarded through their junk mail, through their inbox, through their text messages, through advertisements. And so it's understandable that there's just the biggest misconception is bad information. And I think the hardest part is getting good information.
One of the things you mentioned when we were first jumping on was that a lot of men they don't even know the questions to ask. So as you talk about, you find the right fit, or you're looking to find the right fit in terms of a medical practitioner. Again, somebody that you can trust. You have things that are going on that you don't understand. Again, you're being bombarded by even your friends and all of this, all the noise that is out there and all this. And we don't know the questions to ask. So even if hey, you and I are buddy, and I trust you more than anything, and you've got all this experience, I think what's confusing is, what are some of those questions? Because like you said, you hear this stuff all the time. It can be
Mhm.
normal conversation. There's nothing we would say to you that you probably haven't heard before. I think a lot
Yeah.
of us, including myself, are sitting around going, I'm not so sure what I should even ask. I don't even know what I don't know. I just know that I'm 52. I'll be 53 at the end of the year, and things are really different right now.
Hmm. Yeah.
Um, what are some of those questions you think that, again, guys should be either thinking about or think,
Well, I think if we're talking about the taboo topics, we're talking about low testosterone, we're talking about erectile dysfunction, we're talking about ejaculation orgasm issues, we're talking about bent penis or Peyronie's disease, and I think that there's unfortunately people got to ask us a certain way for us to respond a certain way. But what I like to say is, if it's a low T question, if libido, if drive, if energy, if not feeling yourself is what is driving you to ask the question, do I have low testosterone? Um, it can be as simple as saying, hey, doc, I haven't been feeling myself. I'm a bit off. I'd like to know if there are some metabolic or hormonal causes of that. And that invites that conversation to say, oh, and by the way, I'm feeling this and this and this. Um, a good doc's going to just run it in that list of all these things. But if they don't, when it comes to erectile dysfunction, Viagra came out in the late 90s. We've had it almost 30 years. And I always say that the late night talk show hosts, the Jay Leno's and the Dave Lettermans, kind of brought a cultural revolution by talking about these meds and making the jokes about these meds. And and it is uncommon now that it can be as easy as simply saying, I've been having difficulty with erections. We've already done all of this testing. We're managing my blood pressure, cholesterol. Is there something that I can do to help? Asking the doc simply that. I think, guys, when somebody calls the office about erectile dysfunction, it's because they've been struggling for a long time or something happened and it's a crisis. Um, and I think that crisis makes the discussion feel like a bigger thing than it needs to be. Um, and so just saying, hey, erections aren't the same as they used to be, or I'm enjoying the company of my wife or my partner, but things aren't happening the same. You know, I always say too that I say to primary docs who sometimes reach out and say, somebody would like to come and see you, but they're a little nervous about it. Um, Ask your primary doc to make a referral for that specific issue. Or if you already have a urologist, or if you already are seeing your primary doctor, rather than tacking it on to your annual exam, simply saying, I'd like to make an appointment to talk about sexual dysfunction. You can just call it sexual dysfunction or fatigue or to review hormone levels, sort of these generic things because what I think you got to understand is the person answering the phone in a urologist office is also selected. We get people to come interview at a urology office who say, I had no idea this is what it was. And they won't take the job because they don't want to hear and answer the phone for people talking about their penis or erectile dysfunction or ejaculation. But I think sort of breaking the ice is simply make the appointment. And if it helps, make the appointment for sexual dysfunction, low libido, difficulty with erections, kind of these things that are a little bit easier to say on the phone. Or when you're coming back, breaking the ice with the medical assistant, the nurse. Why are you here today? I'm here today to check my blood pressure. I'd also like to talk about a prescription for Viagra. Just those little one-liners to then, oh, that's why we're here. Because what that signals to us is that this is the reason you're actually here. And we're going to move it further up in the visit too.
mm, erectile dysfunction versus erectile disinterest? Is this a thing? And what I mean
Mm.
by this is, obviously, we hear a lot about erectile dysfunction you're talking about right now, and it's real. How much of it if any, can be contributed to disinterest, meaning like the mind and the body maybe just aren't in sync. Or, hey, like I've had the same partner for like 20 something years. Like it's just, it's lost its luster. It's the same position. It's the same woman, she's going through menopause. It doesn't seem to be as much. I don't think I have a problem with getting erections. I get them all the time. The problem
Mhm.
is, like, I think a lot of guys in midlife are dealing with conformity, complacency, redundancy, and there's disinterest there. There's a loss of passion and purpose and I mean increase in stress. And are they just chasing pills, to fix that?
Yeah, and I think what also happens is when that is happening in a relationship, the elephant gets in the middle of that. And so then the communication creates distance, creates silence, creates awkwardness. It's the gesture across the bed to your partner, and they don't really turn away, but they don't turn towards. And so there's not this leaning into the intimacy. And so there's all of that. Um, I think it's real what you're talking about. I think it's important when I see men in the office to just say, who are your partners? Who are you intending to use this treatment with? Um, I think that, the things that you cover in midlife, stress, poor sleep, inactivity, poor diet, these are the things that lead to vascular disease. We used to believe that 90% of erectile dysfunction was psychological. Um, the discovery of meds like Viagra and Cialis flipped the script on that. 90% of erectile dysfunction is quote unquote physical. It is a vascular phenomenon, essentially, to get an erection. And so, good vascular health, good stress management, sleep, nutrition, exercise helps maintain good function. And erectile dysfunction by definition is a pattern, not a one-off. And so some of the guys here may have said, oh yeah, we went on vacation, we hung out by the pool, had lots of cocktails, went back, I couldn't perform. That's bad luck. That's sort of a failed attempt. But erectile dysfunction is this pattern of difficulty getting an erection and maintaining an erection, um, even with self-stimulation, even so it's the loss of the erections at nighttime, it's the loss of the erections in the morning. um, a little bit of what you're talking about is, I haven't actually heard this term erectile disinterest, but what I know is this is when there is trouble, and I hear this from men all the time and couples, when there's even been one episode, especially in younger men, what happens is that grows, that scenario grows in the brain. Or if there's this growing thought about your partner, the change in their partner, or it's painful for the partner now because of estrogen loss in menopause, um, that fear, that anxiety, that performance, um, that anxiousness that may come from just maybe being less attracted to your aging wife, or maybe a recent family crisis that causes adrenaline to go up. And what adrenaline does to blood vessels is it causes them to squeeze. Erections happen when blood vessels dilate. And so it is that I think it's that self-fulfilling prophecy. So that I think that when there is a problem, and part of the problem is a performance anxiety, part of the problem is a social or relationship aspect, I think we move to that 50-50, right? That you can have good erections at night or in the morning, but that overriding adrenaline, and this is really where I think, meds can be helpful. Meds, as we know them, Viagra, Cialis, Levitra, and Stendra. Most people don't know about Stendra. It was too late to make a splash, but they are simply treating symptoms, right? Viagra will not fix bad vascular health. It will not fix bad sleep. It will not fix low testosterone, poor communication. It will not fix the problems in a relationship. But in this erectile disinterest column, what it could do is maybe restore sexual connection back to a level where the guy is actually feeling a little bit more confident, feeling like they may be able to contribute or participate in the intimacy. And can that restore a closeness? Can that restore a renewed interest? And so I use the example of the young guy who couldn't perform once. He's otherwise healthy. This is a scenario where we'll often give these guys daily Cialis and just say, just take it for the next 6 months because you need more. Take it on a daily basis. It'll get you out of your head. It's not to say it's in your head and you just have to flip the switch. But when you build up success below the belt over and over again, you're thinking less about it. But if you're in a relationship for 5 years and over again, you're like, is this, am I still into this? Am I still attracted? If you are approaching sexual activity with that type of thinking, your odds are probably 50-50 of performing. And then that just builds to the failure column. And we know, not just with sexual activity, but we know when failure builds up and builds up and builds up, then we withdraw. And then it mushrooms into all of these other problems. And so it's this vicious cycle of failure avoidance and failure avoidance. And so I think that they are different. I think that men with normal function probably can have erectile disinterest through performance anxiety or the things you're talking about. And I think in that setting, if it's safe, using a medication, in addition to things like therapy, in addition to things like couples counseling, not just a pill, but the pill is a tool. I think so much of this is about building a toolbox that is helpful for men where they are in their relationships. And if men are able to perform with self-stimulation, but not when they're with their partner, and they're able to get hard, but they can't stay hard, a dose of a medication that is in large part safe for most people, maybe the thing that just tips the scale in that favor. I don't know what you think about that.
Are there ages, either ages or time period or stages, where we should be noticing changes? And those are, let's say, either normal or abnormal changes, meaning, okay, 20s, you're 30, like you're rocking and rolling. Okay, you get to 40, okay, maybe like, okay, maybe it's fewer evening erections, maybe it's fewer more, you're not waking up as frequently, with
Mhm.
morning erection. Maybe it's different degrees of heart. Like, hey, Greg, these things are normal at 53. My Greg, not the other Greg. But anyway,
Yeah.
you're like, these things are no, so that we're not going, wait a minute, like what's happening to me, or what's changing. I
Mhm.
always used to be this. Because now I've taken a bunch of stuff off the table. It's like I eat healthy, I exercise, I sleep pretty well in there. I don't drink alcohol anymore. I have fewer things that I can blame, if you will, for lack thereof of performance. I'm on testosterone, all different
Mhm.
things. I'll be 53 at the end of the year. My wife's 56. There are I'm always kind of wondering, like, sometimes, what if I'm doing all this right? Like, is this actually, is this normal for a 53-year-old guy? Or should this be a little harder, harder or softer,
Yeah.
like for me in there, and things to look out for?
I would ask you the question at 32, were you eating, sleeping, managing stress, and feeding your body in the same way? Because if we think of
Oh,
erectile dysfunction, right. And so the ideal time is probably in our 20s and 30s. To the young men in our lives, we probably need to actually say, continue to do good for your body, keep your blood vessels healthy. When you read the experts in urology who've studied lifestyle modification for erectile dysfunction, their final conclusion always, and for the last 20 years, has been take care of your heart and blood vessels. And so don't smoke, avoid getting diabetes if you can, stay active. All of those things in young manhood are going to help you now. Now, that doesn't take away that there are some things that risk factors, cardiac risk factors, vascular risk factors that we can't control. These are genetics, these are the environmental things that we are exposed to. And this is our past also. We can't change the past. we have to accept kind of the product of that. All of that said, 30% of men in their 30s, 40 in their 40s, 50 in their 50s, 60, 70, 80 in their 80s, 80% of men in their 80s will have erectile dysfunction. And so it matches the decades. And so the question is, well, let's say that someone lived that pristine existence from the cradle to age 50, and now they're in my office with erectile dysfunction. Uh, it's not it may seem a little flippant, but I often talk about the march of life, and that sometimes even when we do better and we do all the right things, the march of life accumulates, right? Just like our hair goes gray, just like we develop wrinkles, just like our joints begin to ache, the march of life happens to us even when we do all the things that we ought to do. But I think what's important is the onset of erectile dysfunction in young men, especially diabetic young men, meaning the loss of erections at nighttime, the loss of morning erections, or the erections that aren't as hard or that don't stay as long, should prompt an evaluation. We say that erectile dysfunction is a little bit like the canary in the coal mine for vascular disease, that the penile arteries, the arteries that trigger the faucet that opens up to fill up the spongy tissue of the penis, is about a quarter the diameter of the coronary arteries. And so the same blood with cholesterol, the same blood with all of the inflammatory mediators of poor metabolism, flush through those blood vessels as well. And so if plaque is developing in the coronary arteries, it's developing in the penile arteries, and it's going to occlude faster. And so the canary in the coal mine is the development of a pattern of erectile dysfunction. You know, I'm fortunate. Most of the men who I see in my office have been referred by their primary care or their internist or their endocrinologist. And so I'm really able and fortunate to talk about, you know, the end result, which is erectile dysfunction. But if someone is having that symptom, we have to think of erectile dysfunction as a symptom of vascular disease. So if someone is smoking, if someone hasn't been screened for cholesterol, if someone is sleeping poorly and has sleep apnea, high blood pressure, stress tests, calcium scores, all of these things, that's the importance of bringing them up. And men have a habit of medical distancing, you know, not going. And that's the other challenge I was thinking about when you were talking. You're 52 now. But at 32, going to the doctor was an as needed event, and only if you absolutely had to, because you had other things to do. And so it gets back to this whole notion of prevention. Prevention happens when we're young, and then it's the accumulation of not preventing, and then the things we can't change. And so it is common, 50% of men in their 50s, and it's usually going to start with fewer erections at nighttime, fewer erections in the morning. Can get hard, but losing the erection more quickly. That's the typical stuff that we see.
How does a vasectomy impact testosterone and metabolism levels?
Uh, it doesn't. It shouldn't. I think that in the Google sphere, there's some people who discuss that it is. But a well-performed vasectomy only interrupts the vas deferens. The testicle attaches to the body by what's called the spermatic cord, and it's about the thickness of your index finger. You know, there's three main you know, there's the vas deferens, there's the arteries, and then there's the veins. Arteries, of course, take blood to the testicle. Veins take blood away, and that's where the testosterone leaves the testicle. When we do a vasectomy through a tiny opening, we take just the vas deferens and we sweep all of those other structures behind. And so, technically speaking, and it's evidenced in the research that testosterone levels aren't affected. Now, that doesn't mean that some men aren't going to experience sexual changes after vasectomy. I make a point to say when I counsel men about vasectomy is this should not affect urination, sexual function. So this should not affect erection, orgasm, or ejaculation, including the amount of semen that you ejaculate. because most of what we ejaculate comes from the prostate, not the testicles. Only a small percentage of the fluid, and so this should not affect that, and it should not affect testosterone level because of what we talked about. The blood supply is not interrupted in a vasectomy. About 10% of men, in my experience, and that's anecdotal, and I tell all men, if in the 3, 6, or 12 months after sexual function has changed, let me know. What I'm going to say is not so much scientific, but it's experience. I find that a lot of those men may have a little bit of a prostate infection, prostate congestion, sometimes just the period of not ejaculating, abstinence. Sometimes prostate gets a little bit irritated, and that can kind of shut the system down. But technically speaking, it shouldn't. And I think the other reason sometimes it's identified is for a lot of men, it's their first quote unquote men's health encounter. Not just general health encounter, not mental health encounter. But in general, if you're seeing a primary doc or a urologist who is doing vasectomies, they have an interest in taking care of men and men's health. And I think it's often a discussion that a lot of people are comfortable having then.
Hmm. What's going on in the low testosterone landscape out there? It seems like there are so many low testosterone treatments now. This has become less taboo and almost like now starting to over-index that anybody and everybody can go get testosterone or be told they have low testosterone pellets, injections, gels, over-the-counter testosterone replacements, in there that are not in there. One, like, how do we make sense of the options? And two, like, how do we know what's the right way as a man to evaluate TRT?
Yeah, testosterone's everywhere. It's been there for a while. It is no longer taboo. And then just the access has improved. I think COVID really put the gas on all of that with the online health providers. And I like to think of testosterone as there's two ways. There's two reasons you replace. There's true low testosterone, and this is levels in the morning that are less than 300 on 2 mornings. And I'll talk a little bit more about testing. And then there's the lifestyle testosterone. And I think if we are distinguishing between the two, most quote unquote primary care docs and urologists are probably working in the low testosterone, the fatigue, poor concentration, poor energy, poor sleep, decreased, physical gains, all of that. And we're testing appropriately with 2 morning levels and then subsequent labs to support that. That's medical testosterone replacement. Lifestyle testosterone replacement is a little bit where it gets a little bit more crazy. And what I think is important, whether we're talking about either, to understand is, in general, testosterone replacement is safe if it is evaluated appropriately and monitored appropriately. And when we get greedy with testosterone replacement, that's when toxicity happens. That's when the side effects happen. And so in that, if we're talking about this lifestyle space, if we're talking about more of the performance or the longevity space, we may not be as caught up in symptoms and numbers gelling, because when we're in that medical space, you can have somebody with a testosterone that's just above normal but feels like crap. And if they used to have a level of 900 and now they're 400, that's a big change than someone who was at 400 and they're now at 350, right? The degree of change. And so when we're talking medical, it's symptoms plus the number. When we're talking, lifestyle or longevity, or both for that matter, understanding why you want to be on it, what are the goals, I think is the most important. Just because the testosterone is low, if you feel fine, you do not need to replace it. But testosterone is in large part safe. We used to have concerns about prostate cancer. It may aggravate lipids, it may aggravate sleep apnea. And so having an internist, someone who is responsible to look for those things, is important. The problem some of us who are maybe a little bit more conventional have with testosterone as it's being played out in the market right now is how people are testing. And so getting back to that question, how do we test? Um, I think whether you are looking for medical reasons or longevity or lifestyle reasons, it's two blood tests between 8 and 10 in the morning. Um, a lot of the and I don't want to get in trouble with people who maybe read this, but it's my professional opinion, I'll say that, is that a lot of the shot clinics, the testosterone clinics, um, are not doing men a favor by how they're testing. They're asking men to come in after work on their way home. And so it's 3, 4, 5 in the afternoon. Testosterone spikes in the morning, and low testosterone is the loss of that morning spike. We all kind of sag through the morning, little peak in the afternoon, and sag in the afternoon. And so
Mhm.
testing a man, a healthy man, at 3 in the afternoon raises the chance that they have low testosterone. And so if we're talking medically speaking, that's probably not appropriate. But if we're talking lifestyle, maybe it doesn't matter. But I think what is important is when you have someone pursuing testosterone for either reason, that you're also checking hormones from the pituitary, FSH and prolactin, and LH, prolactins from the hypothalamus. But these are the things that influence testosterone production. Similarly, if we're talking about symptoms of fatigue and poor drive and metabolism, thyroid, thyroid dysfunction is as common. Um, and with all of this, you know, you asked about treatment. Again, um, we are probably low testosterone because of environmental exposures. We are probably low testosterone because of inactivity, stress, and kind of the downstream effects of things like cortisol that happen through stress and the metabolic instability that is then affecting testosterone production. And so again, it always gets back to addressing those underlying things, those 4 pillars: sleep, stress, nutrition, and exercise. But to your question about how to replace, if we remember that, there's a spike in the morning, if we want to be the most physiologic, daily replacement is probably the most physiologic or cyclical. We're on a 24-hour cycle. It cycles with the moon, right? And so if you wanted to be most physiologic, using a gel or a cream.
Mhm.
A lot of people aren't going to inject every day, but that was the benefit or the proposed benefit of people using gels and creams is you put it on in the morning when your testosterone would normally have spiked, and that is quote unquote physiologic. Now, convenience or inconvenience of the application became the problem. The gels are sticky. They take 3 to 5 minutes. You can't put your shirt on right away. You can't shower. You can't work out. You can't swim. And then if you are going to be in close contact with your partner, you probably need to shower and scrub that off, because with every gel, you're putting more medication on the skin than the skin can absorb. And that then leads to probably a less reliable absorption with gels than with injections. And I think the same could be said for patches. Patches are almost non-existent anymore. It's hard for us to prescribe them. They're great for people that don't like the gel. They're great for people that don't want a shot. But at the end of the day, if you're in my clinic, I think the workhorse of low testosterone is testosterone injections. Um,
Mhm.
and then there's different ways to do the injections. Historically, one of the things, like, not just access to healthcare, is healthcare docs also had to get okay with prescribing testosterone, though it's a controlled substance, and letting men do it at home. When I started practice 20 years ago, men who were on testosterone had to come to my office every week or 2 weeks for a shot. And that was just a barrier and an unnecessary gatekeeping to good therapy. And so understanding the safety and having a relationship that is about testing and monitoring for toxicity, I think makes injections really, really helpful. When you inject the medication, you know how much went into the body. Historically, injections were into the muscle. People would do their deltoid or their thigh, and then for 5 to 7 days, they'd walk around with a sore delt or thigh. A lot
Mhm.
of us now teach subcutaneous, so just under the skin into the layer of fat below the skin. And anecdotally, most of us will say that that allows for a smaller needle, maybe more frequent injections, once a week or a couple times a week or 3 times a week. And I think actually more consistent absorption. That said, any any kind of testosterone prescriber who is just prescribing and not following up, not dialing in the levels, I think is not doing men any favors. I
Mhm.
didn't mention pellets. Pellets are a nice approach for people on chronic testosterone. These are inserted under the skin. They do require a small procedure under local anesthesia in the office. The drawback of pellets is you can't take them out, but most men who I will put on pellets are people who are on chronic replacement and just don't like the shot. But the two most important things of testosterone replacement are a relationship and follow up. I can't tell you if toxicity is happening unless I'm testing. And I know that you are a big fan of regular testing, that you believe on a quarterly basis that regular testing. If someone is prescribing a man testosterone, they should be testing at least every 6 months or 3 to 6 months. Doesn't always need to be a visit, but you need to be checking blood counts. Liver function is maybe a little bit more historic. I always check estrogen. Excess testosterone in the body, especially a body that's not real lean, gets converted to estrogen. Excess testosterone gets converted to estrogen. We also need to be checking prostate, PSA, and then following things like lipids. And so, if you're not following though, or if you're greedy, the toxicity when you're up at the top is where the problems happen. I also think being careful not to overshoot normal. And so I, in my practice, and maybe what I would say sort of generically is if men are starting testosterone and they feel like they're round and around and they can't dial in their levels, ask for a trough level and a peak level. So when you inject a medication, you get an absorption and it gets to the peak. The peak is usually about 2 days after the injection. And so if I'm starting someone on testosterone replacement or seeing a new consult where they're having trouble dialing in, I say in 4 weeks, so your fourth dose, let's inject weekly. On your fourth dose, the day before the morning of that dose, in 4 weeks, get a trough level. That's the level before you inject. How low do you go? And then 2 days after that shot, get a peak level. Sometimes the interval is too long. Like if the bottom of normal is 300 and you're dropping to 250 and you're injecting every 2 weeks because that's what was prescribed, sometimes a lot of people will just say more testosterone, more testosterone. But what's happening is you're getting this high spike, but then you're getting this low. So sometimes just shortening that interval. So I have people who inject every 3 days, every 7, every 10, every 14. We're titrating really to how they feel, but we're also making sure that when they are at their lowest, they are still normal. Similarly, if someone's sitting at 250 and their peak is only getting to 400, you know that that's not good enough. And so you might shorten the interval and raise the dose. But let's say someone has a normal level at trough, but their peak is only 600 and they're still feeling tired. That person needs more med, not a different interval. And so all docs will understand pharmacokinetics. That's what this is, how a drug is processed through the system. And a trough and a peak helps us identify if the interval or the dose needs to be adjusted. Um, and
I
then
think
the
just
final, so, and then there's new oral medications that are available, and the challenge is the historic fear of oral medications is it caused liver failure. The way the drugs are now designed, engineered, it does not do that because of how it metabolizes in the liver. But they're 2 or 3 times a day, and so they're a little less convenient for men.
Mhm. So some of the takeaways on that it's not just the number, it's the disparity sometimes between how you feel and what the number is. Some
Yes.
people can be perfectly normal on a lower number and feel really good. Other people could feel really crummy on a number that's considerably higher than that, in there. It
Yes.
also gets down to frequency potentially of treatment versus again, if you are peak level and trough level because you're injecting, if you will, or taking something every 2 weeks, it may not be the dosage, it might be the frequency, in there to level
Mhm.
to level those things out. Being tested and retested, morning blood tests versus late afternoon, early evening, end of the day blood tests to get a more accurate reading for what you're talking. And then I think the most important one is working with somebody that you trust to read the data, not who just wants to put you on supplementation or is declaring in their algorithm or their sales chart that this is always a low number and this is all, overall. And the answer is always yes, you can get this if
Mhm.
you want it. Let
And I think knowing why you're going on it, what are your goals? And I think also understanding, and this is the other thing that happens when people start, is they expect results right away. For men who are normal, who do lifestyle replacement or optimization or building capacity, testosterone is fuel for all those other things that we do to stay healthy. They may feel the lift much sooner. But for somebody who actually has low testosterone and symptoms, it may take 3 or 6 months for them to actually feel the benefit because the body is used to working under low T and has to get used to working under high T. Testosterone affects, genetic expression, and so that takes time to ramp up. But but yes, I would agree with everything that you said in summary there.
Can we dispel potentially then this notion also that it's a magic bullet that like
Yes.
you go on testosterone and I'm gonna be I'm gonna look better, I'm gonna feel better, I'm gonna sleep better, all of these things on its own. It does help, no doubt. Like at least in my experience, what it's helped with more than anything is it's helped more with energy than anything. It's helped more with energy
Hmm.
and recovery to say, look, the things that I like to do in my life,
Hmm.
whether that's
Testosterone's
my
fuel, but we
family,
still,
exercise, travel, right? Do all these things all day.
yeah.
Okay, which days start early, 6 a.m., ended, 10 p.m., whatever time they ended. What it's helped with more than anything, at least in my case, has been recovery, the ability to be able to do the things I like to do the way I want to do them without having these high highs and low lows,
Hmm.
or early burnout, or just saying, hey, everything I like to do has become much, much harder, basically, you know, in there. And now I can feel like I can do that. But I have noticed, I think dispelling some of these notions that it's a magic bullet. Like, am I stronger? No. Was I bald to begin with? Yes. Okay. Does it help with muscularity? I'm sure it does, but what also helps with muscularity is actually working out more. And the reason you work out more and recover faster is because you have the energy to actually do it. So it's all,
Hmm.
my point is that it's all connected. It's not we can just take this and all of a sudden you look great, feel great, and you have to put in no effort to do it.
Right. I say to men, if you start testosterone and you sit in the basement and play video games all day long, this will not help you. Testosterone is fuel. You still have to drive the car. And it is one of the tools, and I think testosterone builds capacity. For you, it's capacity through energy, and it's the ability to recover more quickly and to show up over and over again, either physically or professionally or in your relationship. um, but testosterone without the tools and all of the other things in the toolbox is probably not, you're simply not going to see the benefit. I tell people this also is, if you've done any cycling, sometimes you're on this long stretch and it looks flat, the false flat. Low testosterone or aging for that matter is the false flat. It looks like things should be fine. Testosterone just levels that. So, and it levels the playing field so that the ride that you're doing or the march of your life, all the things that you're doing can actually be effective and more efficient. You bring up one other point that I have observed in lots of men and is recovery. Uh, and following you online and in your newsletter, I know that you're always discussing your recovery, when to push the gas and when to sort of slow down. And that's different for every man based on what their baseline is for activity. But I commonly see men in their 50s who are very fit. They've done all the right things. They were college athletes and otherwise, and they're struggling with the fatigue. And we check their testosterone and it's quote unquote normal. The first thing I tell those guys is you know, work in some recovery if you haven't. You're used to going 7 days a week and going multiple times a day and going hard, but you need to mix it up. You need to do more sleep. Uh, things that are not going to take all the energy. And so I think recovery for a lot of people is important because low testosterone is a stress response. Meaning when we tax the body over and over and over again, whether that's metabolically, whether that's physically or emotionally, low testosterone tanks. 25% of men with chronic medical conditions like diabetes or COPD, not because they've done anything else, but because they have these chronic conditions and their body is in sort of a fight or flight mode all the time. 25% of those men have low testosterone. And so someone who is chronically charging their system over and over again physically without recovery may end up in that same situation.
Hmm. Reading some of your work lately also on your blog and in your newsletter, you talked about growing gracefully on your own terms recently. What does it mean in the context of sexual confidence, body image? Like, what does that mean? I think a lot of guys now are struggling with growing gracefully, or hey, redefining even what gracefully means. Does that mean we're okay with the nip tucks, the improvements, the other things, or are we just supposed to like it's all supposed to be just natural and we should be okay with it? The changes or the wrinkles, or the bending or the other things that are going on.
Yeah.
What do you think?
Well, I think graceful means different things for different people, right? And who we were, who we are, and who we want to be, maybe three different people, all in the same body. And I think what I sort of say is we should only grow old in the way that we want to grow old, and we shouldn't grow old differently because somebody else is asking us. So when we talk about the nip or tuck, if somebody is telling you to get a facelift and you don't want a facelift, don't get a facelift. But what I know is, growing old gracefully is about maybe fine tuning and recalibrating and sort of finding your foot or coming into your fullness, just like testosterone replacement. Testosterone replacement is part of this growing old gracefully, but it's also growing older with confidence. It's also, taking what we've learned from our youth, learning those lessons, carrying the lessons that are important to carry forward, and then making a decision how we want to move forward. And so I think that growing old gracefully is an option that all men can consider if they want. Um, I write about it because I think it's one of those topics where men don't always know they have agency. I think it is, as you suggest, I think there are a lot of people who say that's just I use the term that's the march of life. The march of life doesn't mean we have to be okay with it. The march of life is just simply saying this is happening. Don't fight it, but can we make the most of where we are right now? And I think there's a lot of people at midlife who are very happy, very very happy with their gray hair, their wrinkles, or otherwise. Um, and then there's a lot of people, who just don't feel themselves, that they feel physically strong, that they feel mentally strong. But if there is something physical, if it's a hair transplant, if it's teeth whitening, if it's Botox, if it's some of the cosmetic procedures below the belt that people are talking about, I think it's about choosing how you show up in your confidence and doing it for yourself and understanding why you're doing it and not doing it for someone else.
Hmm. What are the cosmetic procedures that you're referring to below the belt? The guys are
Yeah.
the guys are coming in for. Is it? penile implants, which you were talking about, is predominantly, medical, or is it I was reading something recently, I think it was about girth. The guys are coming in now and they're wanting to add girth. I mean,
Yeah.
who's doing it? Like, who's coming in for this stuff? Who's doing this? Like, what are the trends you're seeing? Like what's happening there?
There's a published study that says 30% of men worldwide, if they knew that a procedure was safe, would consider a procedure to alter their penis, usually to be larger. And so who does it? It's 30% of people at least consider it. Um, plastic surgery, and this falls into that. This is cosmetic. I think has its history primarily in female aesthetics, but plastic surgery in general is becoming more of a male access. More men are accessing it. Below the belt, we're talking about simple things like blemish removal, laser blemish removal. It might be things like snipping the frenulum, the little tab of skin that attaches the head to the shaft, if that's tight, cosmetic circumcision. Men who have excess skin, like a turkey gobble between the shaft, if they're circumcised, maybe too much skin was taken, and they've got this web and it hides part of the length of their shaft because when they get an erection, there's like the mud flap there. That's a small office procedure to cut that skin. Penile implant is certainly one of them, but it doesn't even have to be surgical procedures. Shockwave therapy, which is a regenerative, we talked about how pills are symptom management. Shockwave is being used for, plantar fasciitis and other orthopedic things. Physical therapists are using it, but shockwave or acoustic wave therapy is used for erectile dysfunction. There is a growing interest in platelet-rich plasma as a way to maybe restore sensitivity of the penis. I personally don't think there's enough data yet for erectile dysfunction. I think that data is forthcoming. The hard part is keeping the plasma in the penis. Um, there's some people who are looking at stem cells, but when so there's all these injectables, including what you're suggesting, is injectables to improve the girth of the penis. Um, I think that there's a few important things there. Uh, and again, I don't want to step on the toes of good injectors, but I think you need to know who your injector is. Somebody who's familiar with penile anatomy, I think is important. Um, it's a medical procedure. It's just a needle, but it's a medical procedure. And I think the most important thing is that you're using non-permanent fillers. Historically, there's a long history of fat injections, of paraffin wax, of silicone injections. All these things cause foreign body reaction, and you get lumpy, bumpy, sore, scarred penises. But what you're talking about in girth enhancement is hyaluronic acid injections. Hyaluronic acid is the same thing that people are injecting into their face for contour changing. Um, the nice thing with hyaluronic acid, and I haven't done it in my practice yet, but the nice thing with hyaluronic acid is it's dissolvable. If you don't like it, you can reverse it. The bad thing with hyaluronic acid is the effects go away 15 to 18 months later. Um, and then just not being aggressive. Just like we all see people who've had too many things done at the same time to their face. Not being aggressive with these procedures below the belt, right? That knowing when to stop. And I think a good cosmetic provider, whether they're a plastic surgeon, urologist, or someone else, is also going to tell you and tap you on the shoulder. I think we've done enough for now.
Mm.
More isn't always more, but no, I think other things. Penile implant. There's an implant for girth. I'm not a fan of it. I think that there are some surgical challenges that are not yet resolved, and so I think if someone on this newsletter world is thinking about girth enhancement, I would say start with injections, absorbable injections first. Um, these, for people with obesity, penile lengthening, people will consider liposuction at the base of the penis to see more of the penis, just like removing that web of tissue is helpful. I do not recommend the suspensory ligament procedure, which has been around for decades. Um, a lot of men actually end up shorter than they started. It changes the erection angle, and the scar is often pretty difficult, and so is the recovery. And then I'm going to add, just as a plug, because I thought about it, using weights for this procedure called jelking. Jelking is there's a real upswing in people influencing about jelking, and jelking is where you forcibly grip the penis, and you're really forcing blood to stretch the penis. All of us who do men's health have men who have sustained injury from that, where they have numbness or they have difficulty maintaining erections because of internal vascular and neurovascular injury. So that's my plug to stay away from that.
Gotcha. I want to turn it to the other side, which we talked about kind of maintaining erections. We talked about Viagra. We talked about all the things about getting hard, staying hard, like performing all. What about the opposite, about turning it down? Meaning you've got a
Mm,
high sex drive, you've got a high libido, you don't have any of these erection issues. You've actually got to turn it down a little bit. And I think for a lot of us in middle age, we also have partners that are in the middle of menopause and other things, and the
mm,
sex drives are not aligned. What I hear, at
mm, mm.
least
No.
what I hear a lot, okay, is that men are trying to be very supportive. They're trying to be empathetic. They're trying to do what they can, as best they can, to support their partners in menopause. And they want to have a lot more sex than their partner does, or it's not as pleasurable for their partner, or so on. And what do we do to turn it down, in there? Is it, you know, there's things around CBD and THC, for enhancement. Is there an opposite of Viagra? Again, I don't drink alcohol anymore. Like, what can we potentially do? I
Mm,
was
mm.
listening to this influencer, unfortunately, influencer,
That's okay.
somewhat credible influencer, but it was like, women go through menopause and we take all this and do all these other stuff. And for men, it's just the blue pill. And I was like, not
Mm.
necessarily. It's like I could take a blue pill every single day, but if I don't have a willing participant, if I don't have a willing partner,
Yeah.
then what am I going to do with this wonderful blue pill induced erection? Or even not the blue pill? What am I going to do with this very high sex drive 4, 5, 6 days a week when the partner's on the more of like once a week
Yeah.
spectrum?
Partner mismatch is a real thing, and it's a complicated situation. And I think every couple's situation is different. You know, the low hanging fruit of what you talked about is menopause. If men had their testicles ripped off, that is the equivalent of menopause. That's what happens to women. And it happens slowly, and it probably starts in the 30s, and so there's probably 5, 10, 15 years of sort of evolution, but menopause is real, and the effects of menopause on interest, from partners, on sex drive, on just the ability to have sex without pain, or urinary problems and infections, is real. And fortunately, menopause is having, I hate saying having a moment, but we have in medicine deprived women of of good hormone replacement therapy for a generation, and there's people who can speak much more clearly about this, but the Women's Health Initiative um, led a lot of us physicians to be scared of estrogen replacement, um, unnecessarily so, and we're seeing the product of that. Fortunately, there's urologists and gynecologists who have just presented to the FDA to change those warnings, but low estrogen results in poor sleep, poor mood, hot flushes, dryness, pain, all of those things. And it's not our job as men to say, do yoga. It's not our job as men to get the prescription and give it to them. It's our job as men to be supportive. And so where couples are where the female partner is interested, pursuing hormone replacement therapy or having a discussion with their doc, for many of those couples is actually a game changer. And in addition to just traditional hormone replacement with estrogen, there's a lot of discussion now about testosterone replacement in women. I've not prescribed it, but there are more and more gynecologists and urologists who are pursuing that. So that can work. There are medications which have been FDA approved for libido and sex drive in women. Um, the trouble we have is male sexual dysfunction was always about the plumbing and the mechanics and the getting the erection. And if the interest was there and the function was there, all you needed was a partner, right? Um, Female sexual dysfunction is a little bit more layered. It involves pain, it involves desire, it involves arousal disorders, and so there's more to it. Is treating menopause with hormones going to fix it? Probably not. Hormones, just like testosterone or estrogen, isn't going to fix, hurt feelings between a couple. It isn't the apology that maybe a partner needs to hear. Um, but to your point, what are the things that you could do to dial it down? Nobody does you like you. So you can have an erection and be turned on. Doesn't mean you have to have intercourse. You can take care of that yourself. Um, Alcohol. Alcohol is a social lubricant to a certain point. Then it gets us out of the mood because we can't perform. Uh, Things like CBD can calm people. Uh, the challenge is that the response to some of these things is very different. For some people, cannabis lowers the inhibition, and so they're using it recreationally to get in the mood. And so, if a couple is open to cannabis, using it or experimenting around sexual function is maybe something they want to consider. I think it's important though for men to also understand is that men are men get aroused and then they are able to perform. Women have to develop and find arousal, and so I often say that starts with the dishes. That starts with communication. That starts with intimacy that doesn't always have to end with intercourse. That starts with vulnerability and closeness. And when men show up in their relationships, not just for sex, but show up kind of in the middle and participate in these other aspects. Women may be more responsive. I also tell men to put it on the calendar, right? That we've talked about sexual dysfunction, and sometimes that just makes it a non-issue that people don't discuss. And then it's so awkward that we don't even know how to try or reach out. But simply putting it on the calendar, if a couple is having sex so infrequently and once a month is an improvement, putting on the calendar once a month, it takes away some of the takes away the weightedness of it. To say that Friday night, we're leaving town, we're going to go spend a night at or we're having dinner or this or that, and that can then start with play through text throughout the day, kind of the flirtation that can help men who have erectile dysfunction plan to take their pills. These pills don't absorb as much if you've had a big meal or fatty food. So maybe you plan a different meal that night if absorption is present, or if for female partners, making sure that they have the lubricants that are needed, or just in my experience, couples who put sex on the calendar actually over time it takes sort of the heaviness out of the duty, and over time it actually, I think, nurtures more closeness and more discussion.
Are there statistics for men on the amount of sex, if you will, we should be having at different ages or stages of our lives? Meaning, again, back to the normalcy, if that's the word of, hey, the average couple in their 20s, or the male, in their 20s, X amount of time. But in your 40s and 50s, you may not need as much sex to remain, vibrant, to be healthy, to be statistically you know, a line.
I, young men are having less sex, and they're having sex first sexual encounter. Young people in general are having first sexual encounter later than they used to, and younger couples are having less sex. Um,
Why do you
I
think that?
tend.
I could just interject. Why
Why do
is
I?
I have two young men. I've got an 18 and a 22-year-old right now.
Yeah, yeah.
Why is that?
I think it's complicated. I think it relates to kind of the world, the digital world. I think that young people or people in general have other outlets to seek dopamine that we didn't have before. I also think I don't have children, so I don't want. I also think that how children may be raised and their access to social engagement might be a little bit different. But I think that media, I think, and sort of dopamine habits have become diluted, right? That video games. I don't want to say it's video games, but people are seeking joy and pleasure in other ways, not just through sexual activity. Um, Pornography is probably part of that, and I think that a little bit to the disinterest piece, that we talked about before, or younger people. The way I always sort of simplify pornography, and it's not simple, it's a complicated drug. I think pornography is a drug, is it is a tool. It's something that when you use from time to time can stimulate, titillate the brain, kind of get you in the mood. But when I see young men who are anticipating, having sex with a partner, or they've had a partner and they've failed, I ask them how often they use pornography. And then when they use pornography, are they sitting at their computer? Are they wearing headphones? And how is that like when you're in the dark, you know, in bed with another person? And so they become experts in the sprint, in the hyper stimulation that pornography, they're 100 meter runners, right? That there's all this visual and auditory stimulation, and they know how to do that. And then all of a sudden you put them out there and you're asking them to do an ultra marathon where the weather, where the terrain, and is different. And so if you become a specialist with pornography, and I think young people have more access to pornography, um, there's less pursuit of that other experience.
I think it's a great point. And I was making notes as you were talking here because I wonder, like, it raises a valid point. If younger individuals are having less sex, less connection, waiting longer to have sex, and what you're seeing is again all the alternatives for dopamine, whether it's the phones and the video games or social media. Then there's also the fear of rejection. Then it's just, so I could just look, porn is easier than going out and meeting people and communicating and looking them in the eye and connecting and all of these different things that are distractions or have replaced you know, the courtship, if you will,
Yeah.
the connection, all of those things. Does it put our kids at far bigger, like, are there far bigger risks than pregnancy and STDs? You used to say like, okay, like the fears were, hey, your children would get somebody pregnant, too young, or they would catch something, or there was anything.
Mm-hmm.
By the way, now there's all sorts of fear of accusation of,
Mm-hmm.
young,
Autonomy and
right, young
consent,
men don't know,
and
right, consent
yeah.
and harassment, or,
But
all,
that's about baseline and boundaries too,
right.
right?
All
And
these
and
things.
and and what you see as normal, and what you may be watching online isn't always normal. It may seem consensual online, but in real life, that doesn't always work out.
Right. And the other way, it could seem, like it could seem like it crosses the line, and guys don't even know how to approach anybody at all because they don't know where the line is. So if I don't
Mhm.
approach anybody at all, and I don't get away from my phone or my screens or how easy it is, or make it transactional or certain other things, even with apps that are like, look, if you want to find somebody and swipe for them, we're on a different top. You can do those things without developing relationship skills, connection skills, intimacy skills, to your point.
Sex is a 13-letter word, communication, right? Just like when we talked about, it starts, with partner mismatch. But I think pornography, if we just go back to that, it's not going to reject you. Walking up to somebody uh, in the hallway at college or at a bar or, at a volleyball, game, that's risky. That takes courage, right? And so I think in a more meta sense, dopamine chasing is all about avoiding discomfort. And when we chase dopamine, we are choosing immediate comfort now over short-term discomfort that may help us in the long run.
Yep.
And I think just there are so many channels for dopamine, and it's not just young people, right? You know, I said I'm sort of retiring from my practice because of burnout. I'm out of shape. I've done an Ironman before and all of that. And a lot of it is because I've chosen sort of things that, not having boundaries and just making choices based on dopamine chasing when, being active and doing these things and getting out and socializing are really the remedy to some of that what feels like burnout or social isolation if you're young or older.
Hmm. Definitely. I know we went kind of on a tangent a little bit there, but I think it's important because a lot of us, again, we're fathers and we're at the ages where our young men, what do we want? We want healthy, happy young men, virile young men to have good relationships, good connection, to not
Mm-hmm.
just be to continue to distance themselves or segregate themselves from intimacy, connection, sexual relations, all that, and replace it again with what is just easy, which is quicker dopamine hits, no rejection. These other things that, as you said, don't necessarily help you overall in life that are there.
Yeah.
Turning it back, sleep and sexual performance. How does the quality of sleep affect sexual performance?
I think there's a few things. Quality of sleep, probably by way of testosterone can affect sexual performance. Men who are chronically underslept will have testosterone levels that are lower, maybe by 10 years. So someone who's sleeping 5, 6 hours a night, as opposed to someone sleeping 7 or 8 hours a night, on average will have a lower testosterone, than a similar person sleeping more. And so good sleep is at least a path because with bad sleep, we're not getting, we talk about the dangers of cortisol, but we also know that cortisol is very good. Cortisol in the morning gives us a surge. That's part of our diurnal rhythm. It's part of the testosterone surge. But when the body is not asleep for long enough, it does not repair. And there is that stress. I think there's a lot talked about heart rate variability and that being a marker of some physiologic stress. But poor sleep through metabolic pathways results in lower testosterone levels. What's interesting is with just 1 week of better sleep, even if you're chronically underslept, you can begin to see restoration of testosterone levels. And then, of course, there's mood and there's stress and there's all of those things that then get in the way of healthy communication and sexual relationships. I think the other
Mhm.
thing with sleep is sleep apnea. Um, I think it's important for all men who get up at night to pee and men who are tired at the end of the day, not just to be screened for testosterone, but to also be screened for sleep apnea. Sleep apnea causes essentially vascular disease. We know that treating sleep apnea can prevent heart attack and stroke. And if we get back to where we started, the same vessels in the penis are subject to the vascular impact of sleep apnea. And so I think that good sleep hygiene is the term is is not just about sexual activity, but in this case, it has metabolic and hormonal downstream effects as well as vascular impact.
Mhm. we're seeing a big uptick, obviously, in virtual medicine right now. I
Mhm.
mean, whether that's concierge medicine and guys are picking up doctors, across the country that they think are very good for them, and they may very well be, in there. Uh, can this can this type of medicine be done virtually? Meaning, like, can these conversations that we have, are they appropriate to be had virtually, or what requires, I guess, in-person visits versus, hey, again, I have questions, or here's what I'm feeling, in there. I guess, like, how should we be selecting, our, I don't want to just say selecting by geography, but I mean, is it expertise? Is it geography? Is it a combination? Do you work with people that aren't near you, and then you go, okay, well, this is something we kind of need to see, we need to
Yeah.
see.
So when COVID happened, um, the world changed for us in medicine, and people still needed care. And there's some people you need to see and touch, see, hear, and touch, right? There's a lot of people that you just need to see and talk to. I am a big fan of virtual medicine, because I actually think that virtual medicine, even if your doc is down the street, is in some ways more effective because you're not rushed. You're at home. You're sitting ready to take the call. You haven't had to fight traffic, pay for parking, wait in the waiting. I think it's more efficient. It's more efficient use of your time. I think that, in traditional medical practice, most states you have to be within the same state as your doc. And so there's that caveat. A lot of the online practitioners, especially in the men's health space, are licensed across many states. And what the experience there is that there is a medical director, there is a hierarchy, and that there are docs in those states or licensed in those states. I think it gets back to I take care of patients who don't want to be on Zoom for that matter, and then people who prefer. I think sexual medicine and men's health is very effective online. And I think it gets back to the quality of the provider again, right? Like, are they screening appropriately? Are they monitoring? Do we have um, shared expectations for treatment? And are we intervening when something's not working and saying that this tool isn't the right tool? I think you can do that on Zoom. Um, Things like Peyronie's disease, surgical procedures, things like that, of course, are going to require an in-office exam. But if we're talking about testosterone replacement and sexual medicine, I think there's a lot that we can do online. And that becomes, what we learned from the online, the big names who are the prescribers for erectile dysfunction, is that men are accessing this information and making their appointments like at 9 o'clock at night when we're not open, when our offices aren't open. And so access and also being parallel with your schedule. If somebody's working 12-hour shifts, 7 to 7, they don't have time to come and see us. But if they can do an online visit at 8 or 9, that may actually get them the care that they need sooner than waiting till they're past that point. Because we know the sooner we get a solution, whether it's testosterone, whether it's sexual function or anything, the less frustrated people become. And when it comes to sexual medicine and performance, the more frustrated people are, the harder it is to actually build that trust and get those outcomes that people can feel that it was time and physical energy well spent.
Is andropause real? You mentioned that, menopause is having a moment. There's no doubt. Menopause is having a big, big moment. There are books and Oprahs and television and individuals now who are making big, big names for themselves, and big audiences, and again, deservedly so, in menopause. There's a large stack of books on my wife's side of the bed. There's a lot of people that she's following. There's a lot of people
Yeah.
that I've started paying attention to and following because I'm on the other
Mm-hmm.
side. I want to know, okay, what are they talking about? Like, what's really going
Mm-hmm.
on? What am I living with? What are we all talking about?
Yeah.
Andropause seems to be a term very few people have heard of at all.
Yeah. So I first heard of andropause in the early 2000s. And so it is not a new term. I was at the International Society of Sexual Medicine meeting in Montreal. I actually met Dr. Ruth at that visit. But it's not a new term. I think it's a marketing term, to be honest. And it is something that we can latch onto to describe what we have been talking about. This shift in well-being, this shift in focus, in capacity, physical, mental capacity, sexual capacity. Andropause, is based in there is a decline, and there is an age-related decline in testosterone. And there's also an age-related increase in what's called SHBG, and this is a protein that binds testosterone. And and so none of us would disagree that there is this age-related decline that is associated with symptoms. I think a little bit different. No, I don't want to say it's different than menopause, because menopause is sort of a whiplash moment right now. But 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 it gets back to what we talked about. If you feel fine as you are, a number is just a number. If you feel lousy, but you have a normal number, that's the opportunity to look for other things. Some of them may be testosterone and a little bit of testosterone replacement. I think if we try to put people into this bucket, if we call it this syndrome, I think we sort of make more of it than it is, because at the end of the day, um, people will find what they need. And I think it's about finding safety and sort of being clear on what you're doing and what your outcome is. So yes, there is age-related decline in testosterone levels. And for many men, that is associated with symptoms, and many of those men will benefit from testosterone replacement. Andropause being that thing that sounds familiar to menopause, because I think it helps us understand. But 20 years ago was a very different time in hormone replacement for men. It was when men came to the office, and we were really gatekeeping testosterone. And so it was part of a men's health movement that didn't just include wellness, because we used to talk about prostate cancer being affected by testosterone. In large part, we don't believe it's that, and in fact, low testosterone may actually be a risk factor for prostate cancer. And so the world has opened up that these hormones are lubricants for normal cell function, and when they decline, things don't function as well. But I think if you're saying, do you have andropause? I don't know what your level was.
Mm.
You had symptoms that certainly fit andropause. You have been very focused in making changes in your lifestyle and your day-to-day to address those symptoms. And testosterone, again, becomes a tool, just like Viagra is a tool, just like estrogen is a tool for women, just like meditation is a tool for all of us. And so I don't use the word andropause in my day-to-day practice. I talk about testosterone deficiency. Um, and then, as I said before, make a distinction between that and lifestyle optimization or longevity replacement.
Understood. Makes sense. So what is next for you?
Well, like I said, I have 3 weeks of active practice, and that's tough because, we're lifers in this career, and I will find my way back to medicine. Starting this newsletter, I wasn't anticipating departing, but this is at least allowing me to be of service and use at least my expertise, to continue to be of service to men. Um, I need 6 to 12 months to not be in the same room as the elephant. The elephant being medicine, and being in that room was very good to me. Um, just it was important for me to take a break for myself. Um, and so ask me in 3 or 6 months what's next, when I don't have kind of the elephant in the room that is my practice. And so it wasn't where I wanted to end up, but it was me choosing my well-being, my mental health and well-being, and it was me getting out before what I was feeling was going to be impacting my patients.
Again, makes sense. Understood. Plans for doing anything fun to flip the burnout to the other side of things? Continue, obviously, writing. I think that there are a lot of guys again in similar positions. Doesn't matter whether they're in medicine, or this, but we come to these intersections, of our career path and choices where do we stay, in this? Can we afford to back out, take some time off, in there? Um, Not necessarily know what we're going to do next, but we know we're not going to sit in this, kind of the way it is, or hey, I could be, do you want to go fishing? Do you want to go like, do you want to, you know what I mean? I think there are a lot of guys that are sitting in this and are evaluating like, and it's a tough decision to walk away, or to really step back and look at, okay, if I keep going down this way, like I said, it could adversely affect patient care, it could affect me. It's more my mental health, all of these other things. And
Mm-hmm.
I'm just curious because I felt it in one industry and,
Yeah,
and at various times of entrepreneurship where passion, commitment, energy just starts to wane too, especially when you've been doing things 10, 15, 20 years, however long it is.
yeah, yeah. I think you know. Um, like I always said I'd love to be a postman. So maybe that's, but that's not fun. That's kind of what could I do otherwise. I have completed a certificate in fine art photography, and that has certainly been on the back burner since 2018 when I did that. And if I think back to 2018, that's probably when I stopped doing that, is when sort of the responsibilities of what I'm doing started to increase that got me to this point. So finding that, I have, I have a creative brain that is waiting to come out. Um, I'd love to, maybe go to cooking school. It's just to have at that, and then of course, travel. I have no plans yet, but I will plan something in the new year that is a real block. Um, but what do I don't know. I haven't thought about that question. That's the hardest question you've asked me.
Did you go from, because now I'm just, let me see, just a lot of similarities here. Did you have a number? Like, was it time? Was there a number? Was frustration or mental health issues leading? And then as mental health issues were leading, or just dissatisfaction going, well, okay, let me just check all. Now I need to check into the other stuff. Can I afford to do that? Can I afford to do this? When can I afford to do this? Your process around making a plan, because I also think a lot of guys get paralysis, paralysis in the analysis, or they feel trapped.
Yeah,
By the way, my mental health might not be great here, but it could be worse if I leave and then I don't have any identity anymore. And who am I going to talk to? And what am I going to do? There's always
yeah,
ways of talking yourself in and out of different things.
yeah.
And I hear this from guys all across the country right now where they're just perplexed. I don't know. Is the devil I know, the devil I don't?
Well, and this sort of gets into, I think, a little bit of woo woo. I have circled with this decision for years as is this the right spot for me? I love the work. The job became the challenge for me, and lack of boundaries with certain aspects of the job is what took me down. I would have said years ago I'd love the option to retire at 55. I'm 50 right now. And so there was a little bit of analysis that had to happen. um, I think all of these things are about foundation. I asked the question, was this a rash decision? Was I just jumping off the cliff? A good friend of mine who I used to work with, she said, if you'd done it after one bad day, that's you being irrational. But this has been coming for a while. But in the background with that is the preparation of, I've it's not a full side gig, but I have a side gig where I'm using my medical knowledge um, not with the newsletter, but somewhere else. So having a little bit of income there to float that. Um, and it is a numbers game, right? I had to make up, for some financial shortcomings because of certain decisions in the past. Um, and subconsciously had to prepare to say that I can't live out loud in a financial way, always having a new car and the best this and that. If I want, access, ultimately it came down to I wanted freedom. I want freedom of my time. And the transaction of time for money is no longer working for me. I'm too young to not work at some level and in some capacity, but it has to be on my terms. And so it's the freedom to say, this is how much I will work, and this is the return. And if I am there, I am there. I had to get rid of a lot of scarcity mindset also,
Mhm.
right? Always feeling behind, always feeling like um, it's the affluenza. Everybody else is this and everybody else is that, and those are those physical shows of productivity where even though I was saving money, our breadcrumbs in medicine tend to be a little bit bigger than some other, I still felt behind. I still felt behind, even
Yep.
though I wasn't. And and then the indecision is a choice. We can choose to make a decision, or we can choose to stay in indecision. And for some people, that's analysis paralysis. For some people, that is just avoidance. For some people, that is doubling down. For some people, that is sort of killing themselves softly and stepping away. I reduced my effort at work as a way to say, maybe if I'm here less. And when that didn't change it, it was like, maybe I shouldn't be here at all. And so the decision, while I was circling this decision, and a number of things had to fall into place, like this side gig. I was at the cabin with friends, and my friend, she said to me this past weekend, she said, I knew when that happened that that was the first thing in you finding the foot to jump off of this treadmill that you're on. And I like, I was given maybe a year and a half ago Arthur Brooks' book, From Strength to Strength.
Yep.
And you're familiar with it, I'm sure, your readers are. Um, that book, I feel many aspects of it was written for me. I've done the hard work. I've put in my time. And I can continue to do that. But if it makes me feel this way, how can I pivot that? And so I am in this stage where I am saying, I don't know if it was a video or something. It's like, was it, maybe it was Arthur Brooks, follow your expert, like lean into your expertise, not your passion.
Hmm.
Because your expertise is what you know, and it'll be easy to do. And then the passion is what you do for fun. I need to find my passion. You asked the question, what am I going to do for fun? I don't know, to be honest. I'm really excited for what I feel like, for what I look like, for what I'm doing for myself in 3 months from now. So I can, with a clear mind, sort of really assess what those things are. And so in the meantime, I'm using my expertise. Starting the newsletter was not in anticipation of this, but as you know, taking action and building evidence that, oh, there may be something there. We're not at the readership that you are, but we're more than I ever expected we would be.
Hmm.
And that evidence is to say, okay, there's something here, and sort of leaning into that. When I don't want to say I felt hopeless, but I was just existing. And and the ironic thing is I'm at my best medically, surgically, I'm at my best. Um, but I wasn't feeling my best. And so I think, I remember, is it Sheryl Sandberg had the book, Lean In, you know, I don't think men step back enough. Women step back to have children, women step back to take care of their families. Um, we are not allowed culturally or expected culturally to step back. And we shouldn't need permission to do that. Um, so I think we look for evidence for reasons why we should and how we can step back. And, it took me 2 months to get to the point now where I'm really looking forward to being on the other side of this career that I've loved and will love again. But stepping back isn't failure. It's actually centering you and what you need, um, and saying that productive time for money is no longer the priority because it's not bringing it to here.
Mm. I'm glad we got here because I think this is really valuable. And I think it, you light up now. Like you're lighting up now, even in being able to say, hey, I don't know what I'm going
Mm-hmm.
to do was with a different kind of demeanor
Mm-hmm.
than even you're great at the technical. Obviously, you're great at the expertise. As you said in there, we can talk about all that. But what's really interesting to see, and for the people that are going to watch this also, and I'll even write about it too, but your general facial expression and demeanor changes when there's this opportunity and possibility of I don't know exactly what I'm going to do, but I know it's not going
Mm-hmm.
to be this right now, and I'm not going to be just continuing to trade time for money. And I'm in a place at 50 years old where I can do this for myself, and I'm not going to squander this opportunity. And invariably, if it comes full circle and I go back to what I once loved and was passionate about and can renew passion, and great. But
Yeah.
the actions that and the momentum that you're talking about, and I don't believe it's the size of the readership per se either. I think, again, people always like they tend to look at outcomes and it's like, okay, well, we've been grinding at this for years, overall. And it goes from a
Yeah.
tree falling in the woods and nobody reading it to one day, oh, wait a minute, like there are thousands of people reading something right now. And
Yeah.
it's really about, as you said, just generating momentum and continuing to move forward. And if you enjoy doing it, you keep doing it. And if you don't enjoy doing it, eventually you stop doing it and you find something else, or you find things within it that you enjoy more than others, or that
Yeah.
other people want to know about. I didn't expect to be having conversations about sexual function or dysfunction with
Mm-hmm.
guys like yourself in my 50s. I didn't have that on
Mm-hmm.
my dance card, on my radar. And what happens, we write about various topics and things come up and guys and go, wait a minute. And guys like you reach out and we talk and we go, well, these things they
Yeah.
are coming up and they are
Yeah.
valuable and they are
Yeah.
interesting. What makes me happy is to try to also be of service and maybe also
Yeah.
getting comfortable talking about things that I wouldn't otherwise talk about. Or, to your point, it's more comfortable doing it this way than it is for
Mm-hmm.
me to actually call a doctor, make an appointment, go in,
Right.
do all the things that other guys are scared to do, also. So I think this is a good way to kind of also bring it full circle. And I appreciate your candor and transparency in it because I think it's important. One, nobody, you can always have choices.
Yeah.
Especially when you're talented and you've got a profession and you've got expertise, you can always use it or you can also always go back to it. And I think a lot of guys forget that. If you don't like
Well,
me,
and what made you successful to this point is still with you. That me start if I started a business, I may not have been an entrepreneur, but I've learned a hell of a lot of stuff being successful at what I do. And so we're not starting from ground zero. And we're just saying this container where I wear navy blue and I show up in this world that is a configuration of my brain is one container in this universe, and that I can have more than one life. And so again, take what I knew, take what I learned, and use it in that next phase. So I think it's also getting to understand that scarcity of I have no clue what to do next. That may be true, but I also have a toolbox of stuff that I will be fine. My financial person said to me, I called him up. Sorry, I know you were wrapping up, but I called
no,
him up and I said, if I left, and this was months ago, if I left and I was going to start a business, is there a line of credit number that I could access on my retirement? And he told me the number, and I was like, oh, okay. And he's not one to give lots of advice. He's conservative, like so many of them. He said, I want to ask you this. Are you good at what you do and are you smart and capable? I said, yeah. He says, then bet on yourself. And that betting, that conversation, that betting on yourself, uh, I think was the pivot. That, and my partner always says you can change your life in 1 year. And so those two things happening this year just fell into place. And so the betting on myself, the first step was the action to leave.
I love that. I think it's great. And I think far too few men do it
Mhm.
for a variety of different reasons, including just not having somebody in the corner to offer them permission in a way too, the permission that they
Yeah,
think they need, which they could give themselves.
yeah,
But it's difficult, it's challenging. And as you what you talked about really also is the value of importance of having a good partner, having good advisors, and having ultimately the confidence and security to be willing to then go out and actually bet on yourself and take the action. And
and not have to have it all planned out. You can
yes,
figure it out on the way.
yes, and the hedge, if you will, in not having it all planned out is I can always go back, or I'm always
Mhm.
going to be a capable person when I'm not
Mhm.
letting my medical degree lapse, license lapse, or any of
Yeah,
these other things, and
yeah,
I'm going to be okay.
yeah. Cheers to that.
Yes. James, thank you so much. I really enjoyed this.
Thank you, Greg.
Your
Yeah,
wealth
I
of
appreciate it.
information, and I'm excited about it. Will you do me a favor, and I'll email you too? Just send me some pictures, some
Okay,
lifestyle photos that we can include with the article and the interview on the cover.
okay.
Um, Obviously, doesn't have to be in your scrubs or anything like that. We're moving on, but even if it's examples of photography or any things that represent you, because I think it's important. Again, we talk about the individual. Like, yes, you're a wealth of
Mhm.
knowledge and expertise, and we'll frame this there. But I think now, as we come to the conclusion of this conversation, there are a few aspects of this conversation that I think are very, very valuable. It's all valuable in the aggregate, but I think what we just talked about in the last 10, 15 minutes is super, super valuable to guys that are out there. And I think what we spent a lot of the time on kind of the nuts and bolts, if you will, and Q&A around the sexual issues and questions that guys have and don't always ask also is extremely valuable. So I think there's a number of ways we can also put this together and do this.
Sure.
And bear with me because it may end up being a couple of things, in there too.
Okay.
Yeah. So
I'm
thank
here for it.
you very
I'm
much,
here
man.
for it.
I appreciate it. And if there's anything I can do to support you, let me know. Happy to obviously promote and cross promote what you're doing in your newsletter. So
Thank
just
you.
also when you send the pictures over, just make sure I have whatever links, whatever things you want to talk about in there so we can help you continue to grow as well.
Much appreciated. Thank you. This is a great opportunity.
You got
I
it, man.
hope you have a good day.
You
Cheers.
too. Take care. Thank you.
Bye.